I will be talking today about addressing trauma with an equity lens. And my hope is that in the course of the presentation, we can go from structural context to some of what may be more proximal in the therapy context. And so beginning with structural inequities as a cause of trauma, some of this, I think, or much of this background is going to be very familiar to all of you, given the work that you do. But I want to be sure to situate us in some of the concepts that I think are relevant in this area. And so if we move to the next slide, one of the pieces that I think of as most important as a psychologist who was really trained as a school psychologist, so really focused on development and on ecological context throughout the lifespan, is the idea that when we talk about social determinants of health, we really are talking about how they impact across an individual's entire life and in their broader context. And so I find the World Health Organization life course model to be useful for thinking about this because it really highlights how these exposures, the accumulation of both positive and negative effects on health and well-being really begin in the prenatal period. And they go on through the early years and certainly up to late adolescence, young adulthood, but throughout the entire lifespan. And the idea being that once they accumulate, not only do they accumulate over time, but there is also this impact on family building and then some of these inequalities being actually perpetuated over generations. And so some of the things that come up in this model are that broader context, certainly the wider society, but also importantly systems, including the healthcare systems and community health systems that many of us work in. And so to give my definition drawn from other work on the social determinants of mental health is we're really talking about differences in the social, economic, and environmental circumstances that people live in. And that impacts as well the services they can access. And so again, many of these, extremely familiar to all of you through your day-to-day work, right? We have adverse experiences, poor education, unemployment, neighborhoods, food insecurity, any number of factors that really impact not only health, where we often talk about the social determinants of health, but also mental health. And importantly, considering that structural racism and socioeconomic status are fundamental causes of these conditions. And by fundamental causes, that really means that the mechanisms may vary for how they play out, but these are always there underlying the different exposures and experiences that people have over the lifespan. And so then that really is what leads to what we think about as health inequities or health disparities. And again, importantly, inequities and disparities are not things that occur only to individuals. They are systemic. They are produced by our society. So we have the capacity to change them potentially, and they're unfair. And the accumulation of them really can create a cascading effect over the lifespan. And so importantly, this leads us to the idea that interventions have to be systemic, right? They have to address root causes rather than only individual experiences. And I know this varies across the mental health professions. Some of them have more focus on context than others. Certainly in the area of psychology, we have quite a history of focusing on individual context and experiences rather than on systemic interventions. So in the context of equity, one example that we can think about is the emphasis on understanding adverse childhood experiences, which really was, an important advance in thinking about the ways that trauma in childhood impact health across the lifespan. But the original ACEs model really focused on individual and household level exposures, like experiencing physical, emotional, and sexual abuse or neglect, as well as experiencing household adversities like interpersonal violence, substance use by family members, and so on. But these were really derived originally from studies with primarily, well, first of all, with adult populations, but also with largely white middle-class populations. And so work since then has really argued for the notion of expanded ACEs, right? That we're missing a lot if we only think about household level adversities, because we actually have a number of adversities that occur in the environment, ranging from community violence to experiences of racism, to neighborhood context, and then more specifically experiences like being in foster care or being separated from a caregiver due to immigration. And part of the reason it's important for us to expand this concept is because if we don't, we really miss some of the most important experiences and adversities that are being faced by minoritized populations. And so this really expands the focus into, again, these socially produced determinants of mental health. And so again, with this question of trauma and how we think about trauma, there's certainly individual experiences of trauma, but we also have historical and community level traumas, intergenerational trauma. And so trauma, much that we know now about how trauma can be transmitted from, parents to children across generations, and how those experiences can impact children who didn't necessarily have experienced the original trauma themselves. Racial trauma, and then the idea of cumulative trauma, that the accumulation of adversities can have a different effect than a one-time experience. And then finally, vicarious trauma, which is relevant certainly to many of the people that we might be working with who've experienced vicarious trauma in, for example, witnessing violence or hearing about violence done to others, even if they didn't experience it themselves. And it also applies to all of you as mental health providers or as people working within the mental health system, because there is also the vicarious trauma exposure to others' experiences by virtue of working in this field. And I wanted to put in these slides, again, it's more of the conceptual, but to give some, some additional resources. This particular model that is really a developmental and ecological model of youth racial trauma by Salim, Anderson, and Williams. And I think very relevant not only to youth, but certainly young adults, and then how this impacts across the lifespan. But again, what they really focus on is the idea that there are developmental differences in how racial trauma impacts an individual depending on their point in development. So there are different, cognitive, emotional, and sort of social experiences or tasks that relate to how you understand and make sense of these experiences. And so the experience of racism in elementary school, versus in adolescence or young adulthood is going to be different and have a different impact. And that these experiences are also embedded in ecological context. And so it makes a difference, if you have context including parents, family life, schools, or healthcare systems that address racial trauma directly and are able to help mitigate the effects, or in some cases actually perpetuate racial trauma. And I think schools are a very good example of this, because you can have a strong impact of school environments or workplace environments in creating inclusive environments, but you can also have those really be the places where people experience pervasive trauma. And some other aspects of this model that I think are relevant to understanding how trauma impacts minoritized populations is the idea that this epigenetic vulnerability from historical trauma is also at play. And so a lot of this, the documentation of this we get really from research with Indigenous populations and from Indigenous populations about how trauma historically has really impacted the well-being of communities. And then this really also addresses the idea that we have some real limitations in how we think about post-traumatic stress from a DSM perspective, as related to something like racial trauma, which again can be pervasive throughout the lifespan and also may have different effects. We think about DSM post-traumatic stress as being related to life-threatening experiences, but we know that exposure to racism and racial trauma can lead to those same effects in terms of the wear and tear on the body and on mental health. And again, this model also importantly emphasizes that we need to prevent racial trauma. We need intervention after the fact because it's a reality that we are dealing with. But we also need to understand that our goal is not only to help people cope with unjust conditions, but also to prevent them before they occur. And so where does that take us in terms of the link between these structural inequities and the actual treatment that we provide? Trauma-informed treatment. So if we go to the next slide, we want to first situate that in a definition again of structural racism. And so moving to again, an emphasis on how we think about these issues at a structural level, not at an individual level. Structural racism disadvantages people of color, and particularly Black and Indigenous people, at the level of societal systems. And so these are systems that shape power structures and they shape access to material resources. And that includes our healthcare systems, as well as the larger social structures, institutions that shape our healthcare systems and our other community systems. Importantly, these systems are interconnected and mutually reinforcing. And so that is one of the things that makes it challenging, right? You can't address these issues at an individual patient level, and you also can't address them at just an individual level of one system or one health agency. They are going to be interconnected, and we'll give some different examples of systems that do that and that are then mutually reinforcing in the efforts to maintain the social disadvantage structures. So in this example, this is a framework that some colleagues and I worked on, and it focuses particularly on suicide prevention, but is also relevant certainly to other aspects of the mental health service system, particularly in situations that often lead to crisis type interventions. So what we really focus on here is the idea that racism occurring at the multiple levels from cultural and institutional down to interpersonal really impact the broader system that our services are provided in. And so ultimately, this impacts every aspect of what we do, from prevention services to mental health services to crisis response, leading to unequal outcomes for individuals as they engage with this system. And I'll give some examples of how that occurs. So we focus in this particular paper on really three pathways affecting youth and young adults. And again, if you really are thinking about this idea that these systems are interconnected, we're thinking about these pathways as being the points at which different systems somewhat converge to produce better or worse outcomes for youth. And so for outpatient mental health, this is an area that will be very familiar in terms of disparities. We have documentation of racial and ethnic disparities throughout the entire mental health continuum. So we know from the literature that youth of color are less likely than white youth to receive outpatient care for depression and anxiety. So they're less likely to be seen in sort of the traditional specialty care system. Emergency department visits for Black youth are more likely to result in physical restraint compared to visits for white youth. And so arriving in these sort of more emergency settings can lead to very different outcomes, leading, for example, white youth to receive potentially a more supportive intervention as opposed to being met with physical restraint or with other traumatic experiences. And in a study that was, important but also very concerning, one analysis found that therapy was actually less effective for Black youth. And so this was looking at sort of evidence-based therapy delivered in clinical trials, and found it actually had less of an effect for Black youth that resided in states that had high levels of cultural racism. And so they had a sort of state level indicator, finding that even if the therapy itself maybe was being provided well, the outcomes for youth were actually different when they were being exposed to these high levels of racism. And so again, very concerning for what happens, at the level of individual treatment and how it's impacted by the broader context. And schools were another important pathway that we focused on because, again, we're all, I think, probably very familiar with the term school to prison pipeline that really refers to the idea that Black and Indigenous youth receive higher rates of punitive discipline compared to other racial ethnic groups in the US. We have evidence that Black youth and youth with disabilities are more likely to be suspended or expelled from school. And we also know that this also has an effect on school belonging, which is a protective factor for suicide, for mental health. And so all of it, taken together to really emphasize the fact that for youth of color, you have a pathway where mental health concerns are actually being addressed in a punitive pathway, funneling into discipline, behavior management, all the way up through the juvenile justice system. And that's being done instead of providing mental health care. And so it's a different pathway through the system that leads to very different outcomes. And then finally, and I think importantly for all of our work that relies on, responding to acute mental health crises, the other area that we address is that the intersection between our crisis response system and our law enforcement system, and knowing that our crisis response systems really rely on 911 and on law enforcement responding. But this links suicide prevention to racial disparities in policing that are well documented. And so, no easy answers in this case, right? Because 911 is, typically our, one sort of 24-hour response system across the country. There are a lot of challenges in rural areas, for example, with getting other types of mobile crisis response, and it really varies state to state, county to county. But it really raises the issue of how youth are getting into the system. And what we find also from the disparities work is that youth of color tend to enter the system through these crisis pathways. And so we see large increases in psychiatric emergency department utilization for Black and Latinx youth, which is really taken together with the idea that there's less outpatient utilization. So there's less sort of usual ongoing care and more access to crisis care. And finally, we know that this really impacts the trust in care pathways, because you're not going to pursue a care pathway that has been punitive or resulted in involuntary hospitalization in the past. So again, that paper was focused more broadly on suicide prevention, but it certainly, some of the documentation there really reflects the patterns that are seen in treatment for psychosis and schizophrenia. And so we know that there are disparities, right, in who gets diagnosed and what the treatment outcomes are. And this occurs both by race, ethnicity, and by migrant status. There's differences in the use of physical and medical restraints for patients experiencing psychosis based on race. And again, we see that same overrepresentation of patients of color with psychosis in emergency room and inpatient settings, but an underrepresentation in outpatient settings. And again, Black and Latinx patients being just more likely to enter the system via an original crisis care intervention, which also points to the notion that symptoms are more severe at the time of intervention. So the question then becomes, what do we do about that as individuals or as providers? And what is our role? Because there's certainly a role clearly for systemic change and for policy change. But what about our day-to-day work? If that's not the day-to-day work that we're doing, what does this mean for us in our work? So some examples really then have to do with what we boil down to in the patient encounter, right, or the client encounter. These, I put unconscious or conscious bias, because often in the healthcare system now we're talking about unconscious bias, and there's a real question there as to whether that's a sort of sanitizing, right, of overt racism that's happening in encounters. But there are some things that are fairly pervasive that can go unnoticed. One pure one is using white as the comparison or norm group. The idea that there is this sort of default culture, which is really a white middle-class American culture as compared to others. The colorblind ideology. So the idea that, I don't see race, I treat everybody the same way, which really impedes both honoring, cultural differences in individuals, but also impedes identifying the sources of bias that all of us carry in different ways and being able to address those directly. There can be a downplaying of the impact of racism or systemic challenges on patient experiences. So a person might come, to say, well, I had this experience with the front desk staff, or I had this experience with my other therapist. And instead of really being able to listen and to honor the experience that person had and identify solutions, there's an emphasis on downplaying and on trying to sort of defend the system against that accusation. There can be stereotyping and just making assumptions about patient experiences. And I'll have a case example that really focuses on that, but on the idea that sometimes we almost go in the other direction in many situations where someone might say, well, I had, I've learned this about this culture, and so this must be true about all the patients that I encounter from that culture. And then really noting the importance of first encounters, what we are saying to people, what we interpret about their symptoms based on our perception of them, and being able to be reflective about that. And I will say that, one of the challenges with this is that we have moved a lot in healthcare to things like unconscious bias training. And really the research on that is pretty mixed at this point as to whether that impacts actual healthcare outcomes. There can be a benefit from that type of training of really bringing to light people's biases and experiences and bringing some awareness. There can, in some cases, be a backlash where people become aware of something that they are not really that comfortable with, and then they sort of resist, any kind of change related to that. Or there can be the idea that it brings it to awareness and you care about it, but you don't really have solutions as to what to do. So there is really an emphasis, at least from what we know, on the idea that that sort of training would really need to be combined with sort of more practical experience and more opportunities to actually apply that in your own setting. So at this point, I always like to talk about this particular approach that was actually put together by two sociologists. So This is really, though, something that I found to be really practical. I mean, in some ways, there's some jargon here, and so I'll try to explain it. But I think when you boil down to it, I found it to be practical in actually understanding some of the things that I think typically happen and that I know I saw happen quite a lot in nonprofit settings before I became a therapist and then later as a therapist. But really what they talk about in this paper is about the idea that, we think about social exclusion and unequal outcomes at the big sort of systems macro level, but that these are shaped every day by micro level social processes, by all our interactions, with each other and with other people. And what they really argue is that these are the processes that keep people from being able to accumulate sort of the same social capital and have the same experiences. And so again, these terms, some are more memorable or useful than others, but on the next one, I'll explain what each of them are and give some examples that for me at least stuck with me and hopefully will help with a little bit of understanding these processes. So the first of these that they talk about is othering, which is something we see every day, and is the idea that as individuals, as groups, you really create an identity in our social context, in part by distancing yourself from other categories of people. And so there's this effort to distinguish oneself that often comes with the idea that there's another group that's different from yours. And so there's sort of a group identity of yours that is different from others, and often that there's another group that is inferior to yours. And one of the things that they talk about is really that this happens between groups. And so people will distance themselves, from groups of other nationalities, of other races. But it also happens within groups. And one example that I can provide for how this happens and can happen in a pretty dynamic way, like in a changing way, is, working with Latinx immigrant parents in a community that had been historically an immigrant destination community, and working with parents, in 2019 and having some of them say, this used to be a community where everyone was proud to be an immigrant, and all of us, kind of that was our commonality, that we were all immigrants. And they said, and in the last few years, that's changed because now people point out to you if you're undocumented, or they talk about undocumented immigrants. And so now within this community that had sort of a shared identity as immigrants, there had been this othering of one group saying, well, actually, maybe we're a little bit better off because we're documented and you're not. And there was this effort to sort of push out this other group and to sort of distance themselves from the rhetoric towards immigrants by at least saying, well, we're better off, or we're a different group than you are. And in this community, it was reflected not only in what the parents said, but it was also then seen among the kids. And so when we talked to teenagers, they were describing really different dynamics in their school, all up to kind of slurs being used for more recent immigrant youth, to the expectation that recent immigrants would sit on a different part of the cafeteria. And so there was this really active process that people in the community were being impacted by, again, of othering. And I think when we think about this in the professional setting, we have to think about the ways in which sometimes groups of professionals may do that to each other, based on their sort of identity as being part of a particular, having a particular training or being from a particular professional system, but also that it can happen between those that are, caring for clients and the clients, right? So distancing themselves as in different, from this group of people. And then another area that they talk about is the idea of subordinate adaptation. And so the idea that we can have strategies to cope with being in a disadvantaged position, but these strategies can then keep that same social hierarchy going. So a very, kind of straightforward example is, youth dropping out of school. And so leaving a school that might be a racist system, where they've been disadvantaged and not being given the tools to do well in school, and really exiting that system in order to work or to do other things that may help them cope with that temporary disadvantage, but that in the long run really perpetuate the social hierarchy, because now this student is out of school and doesn't have a way to get a diploma and doesn't have a way to move up in their jobs. And so there can be these ways that the social hierarchy is also just sort of perpetuated by adaptation in the moment, which is ultimately not as useful in the long term. And then, there is the idea of boundary maintenance. And so the idea that groups will control and limit access to resources. So they might control another group's access to resources, or an entire community may do this. And so again, going back to the school example of these youth that were saying, well, these kids can only sit on this part of the cafeteria, that's a very kind of a blatant, limitation of access, right, to being able to socialize or be involved with the larger school community. But there are certainly many ways that we see this happen all the time, where one higher income community says, well, we're not going to allow that substance use treatment facility to be established here, or, an area that, previously had a shelter for people who are unhoused, becomes a sort of up and coming, area in terms of businesses. And now they start trying to push out the services that exist there, to other areas that are less convenient, for the people served. So there are lots of different ways that these boundaries are being sort of set up and then maintained. And again, the question for us in the healthcare system, right, is what resources do we maybe have within a clinic or within a program? And how are we controlling access to those resources? How are we deciding who gets this resource and who doesn't? And are we deciding deliberately, by saying, well, this program will be open to this group of people for this reason? Or are we sometimes deciding just sort of by attrition because we've established a program but not provided transportation, or we've put it somewhere, or at a time where people can't access it? And linguistic access is part of that as well, right? When we're not providing access, in different languages, then we're automatically saying, well, this resource is not going to be available to all in this community. And so importantly, these three things, if we go back to our original concept of trauma, these are ways also that trauma and traumatic experiences get perpetuated, because we, are navigating systems that potentially are excluding us repeatedly, or are limiting access to resources, or are creating the impression, right, that a particular group of people is not worthy of the same things as another. But the last one that I think really, for me, struck me a lot from early experiences working in social services is the idea of emotion management. And the idea that for all of us, really, the emotions that are evoked by inequality, by experiencing it, by seeing it happen to others, are intense, right? And they can include anger, they can include resentment, they can include despair, they can include sympathy, right? So maybe we're not directly affected, but we see it happening to someone else and we really care about that. The idea of emotion management is that in a society, these emotions need to be controlled, because if you don't control them at the level of a society, then people will actually start making changes in response to these emotions. And so systems themselves, in order to sort of calm those perceptions of inequality, may make that effort to manage the emotions. But individuals can do this too. We can also decide to suppress our own emotional reactions. And so the reason this struck me quite a lot is because in this paper, they gave the example of people working in like a government agency, deciding who receives benefits. And the idea that the training was very overt in conveying to people, conveying to the workers, that they should not empathize or sympathize too much with the people that are coming to them. They should not listen to their stories too much. You really have to focus on eligibility for the benefits and like just kind of stay focused on the facts of the matter, because otherwise you're going to get overwhelmed and you can't make these decisions based on feelings about other people. But that ultimately what this does is it really disconnects you, right? It says, let's forget about the human experience here, which is very, which is evoking a lot of emotions, and let's just focus on getting the job done. For me, that resonated with early experiences, when I was in one of my first jobs in a school, where people said, you've got to stop being so distressed by the stuff that these kids are going through. Like, this is just real life and you've got to get here and do your job. And that's the best way to do it. And it's true that, we do need boundaries in our jobs. So it's not that I'm arguing for just sort of letting emotions rule the day only, but that there are a lot of ways that we have been sort of socialized in these settings to disconnect ourselves potentially from the experiences that people are having with the systems. And that makes it ultimately very hard for us to respond to inequality, because we are, hearing about experiences, and either, the options are either, well, you really connect to those experiences and therefore you don't fit in at this job, or you don't connect to those experiences at all and you start feeling disconnected from your work. So being aware of this dynamic, being aware of the idea that there are emotions evoked by inequality and that those emotions have to be addressed and dealt with, and we have to find healthy ways to process that information and to take action where relevant. I think for me is an important insight into the individual level experience of unequal systems. So some of the information I've presented, is pretty dire, right? There's a lot of these things that we encounter and that you all encounter in your day-to-day work where you really start wondering, can things change, right? These systems, how do we change these things? So the question comes up, what's an example of a system changing? And I would say that a very good example is the work that you're all involved in, right? Which is in early psychosis care. So if you go to the next slide. We really think about this distinction between a socio-ecological model and a traditional medical model. And it's not to say that, one of these is better than the other, right? But they're complementary and they have different purposes. And so in the traditional medical model, you really have this individually focused approach, right? The goal is to treat an acute illness or injury, something that is happening in the moment, it's threatening, it has to be fixed. And there's a reliance on experts. You go to a doctor because they know what to do. There's a linear perspective, which is that, if this thing gets resolved, if you think about a broken ankle, for example, there's an acute injury, it has to be, treated. It will, be able to be resolved within, X number of weeks. There will be this rehabilitation period, and at some point this will be over and you'll be sort of cured and rehabilitated and back to normal. So we have that model, and that's really, again, not true across the mental health professionals, but certainly within some of our mental health professionals, there has been more of a medical model of treating also mental health conditions, is really being about treating an acute sort of condition and seeing what can be fixed. Whereas a socio-ecological model is really focused on context, right? It's focused on prevention. It's focused on caring for people across the lifespan, right? It's not just the one time they show up and getting to the end of that treatment episode, but it's really about how are people, thriving throughout the lifespan and what's being provided to them. And importantly, it provides a systemic perspective, but also one that incorporates multiple perspectives, right? That says not one of us is an expert. Everyone, including the client, is really an expert on what's happening here in different ways. And you're putting those different puzzle pieces together to provide the best understanding of the situation and the best care. So when I say, that early psychosis care is really an example, right, of how systems change, it's because we really realize that, this is a situation in which you really think about psychosis and schizophrenia and other conditions as being these sort of serious mental illnesses, right, by the US, the congressional definition, which are really conditions that can be diagnosed. They are recurrent, they're persistent, right? They don't go anywhere, they're with you throughout the lifespan, and they cause impairment in one or more life activities. And so there really had been, from a medical model perspective, right, there's been this idea persistent for a long time, even though these conditions are, under different names historically, but the idea that there are just these kind of mental health conditions that will strike and that's about it, right? Now you're just kind of managing it, for the rest of your life, as opposed to the recovery movement, right, which is a systems change that occurred over time, right? About emphasizing recovery, about emphasizing the process of living with a condition, about putting the power to individuals to make decisions about their own care, about the importance of peer support from others with lived experience, and about the goal of achieving independence, right? That this idea that functional impairment, from again a diagnostic standpoint, is not, something that just happens to you and that's it. That there can be recovery and work to be independent in these different domains, and that this can change over time. So this is really an example where we have seen systems actually change quite dramatically, even though, of course, it's not, 100%. It's not that everyone thinks this way or is able to organize systems in this way, but the change in the perception, the change in the understanding of what can happen and what should happen has really been quite profound and is a good example of systems changing towards conditions of greater equality. And so, when we think about those gradual changes, right, it's the idea that we can identify these prodromal symptoms, that there are early signs and symptoms that precede the development of a disorder. The idea, and then, the research showing that the treatment of these symptoms could delay onset, could improve long-term outcomes. and that over the lifespan, there's this greater consideration of how we address social integration and independent functioning. And so living with, the conditions rather than trying to isolate and say that this is something that can't be addressed. So that to me is an example, and I don't give more details because you all know, you know it better than me, right? You live it in terms of the work that you do. But again, where there's a real change in what happens within a system and therefore what can be done. To give a patient example, this is a little bit different. This is an example of how at the patient level, right, the intersection of race, culture, and language can really impact outcomes for a patient. And so this one, I'll just present it briefly, but I think it's an illustrative example. It comes from a patient I worked with, but it's actually a situation I've come across in various forms. And so this is a patient who was a 16-year-old Latino male. He was actually being treated in an inpatient psychiatric setting for major depressive disorder. And the admission had been precipitated by a suicide attempt. So this is actually reminiscent of that idea that presenting at a certain level of severity, this was somebody who didn't have any mental health history prior, hadn't really received any care, had a suicide attempt, and was admitted to this inpatient unit, actually at a state hospital. So his family background really was indigenous Mexican. The parents were Spanish-speaking immigrants. They were from a rural area living in the South in the US. The family was working class. The patient had grown up in the US and was Spanish-English bilingual, had been enrolled in school, had been doing fine in school up until this point. And so I came into this as a therapist, and this patient was referred to me by the unit social worker. And the social worker told me, the patient has requested a Bible. He wants regular meetings with the chaplain. The patient carries the Bible everywhere. He reads passages aloud to himself repetitively. He frequently prays. He discusses religious beliefs with others, right? This was a big focus of his time so far at the unit. And when I went to a sort of multidisciplinary team meeting, I realized that there was this sort of assumption that had been made by various members of the team that was, that this patient is just very religious, right? And someone even explained to me and said, well, he's Latino and, his parents are from Mexico and this is a very traditional family. And so this makes sense. Like he's just really relying on religion as a coping strategy. But when I met the parents, right, so I asked them because I wasn't, I didn't know, I don't know what their history is or where this fits into the patient's life. And I remember it very well because when I asked the parents, if they were religious, the mom actually laughed and she said, we're like the least religious family. We don't go to church, we don't have a Bible in our house. This was something that was just not part of their lives whatsoever. And she was actually really confused and shocked by the level of reliance, that this patient had on religion. And I asked, was he interested in this before? And she said, no, absolutely not. This was something we'd never heard about, until like a few months ago. So again, this is not something, we're not going in depth into the situation. At this point, I don't know necessarily what this means for the patient. I mean, maybe he did develop a religious interest, or maybe this is a different, type of compulsion that he's developed, or maybe this, means something else entirely. But the idea is that at the level of treatment, there had been major assumptions made by a care team that because of the patient's background, this must be a patient that does, XYZ, that is religious, that his family must feel this way, that this is just the way things are, for this person that comes from this particular context. So this is a really good example of where stereotyping can take place and interfere with care, even if it's not, it's not badly meant. There was nobody that had any kind of, bad intention about this. I think some people thought they were trying to be actually culturally competent and open, but they didn't have the simple sort of, asking the family, gathering the history, understanding that there may be different ways to look at this. So again, an example of how assumptions can really play into care. So where do we land in terms of solutions? That's something that we can discuss because solutions are different in every context. But there are some themes I typically will point to, which is really thinking about this idea of the well-being continuum that really moves from, this is very small print on here, so you might not be able to see, but kind of actually starting from the right over to the left. That we really can move from the conditions of injustice, which really involve suffering, suffering, oppression, like feeling, having to internalize these issues, up the continuum through confronting, which is more about confronting the conditions of injustice, but is still a pretty precarious position to be in. Up through coping, which I would argue is often where we are in the mental health field, which is kind of resilience, adaptation, compensating for these issues that are happening, which is something. It's important. We have to do it. But it's still, in this continuum viewed as suboptimal. It's not optimal to sort of be in a condition of injustice and just be teaching people how to cope and how to adapt to it. And that the optimal condition that we're striving for is, promoting conditions that are good for people from the beginning, which involves prevention. It involves freedom, for individual development and pursuits within a context where people can thrive. And so that is, in the idea of solutions really begin first with shifting our frame of what's possible and what the ideal is, and that the ideal is not coping, but it's actually about thriving and about changing these conditions. So to a takeaway is really that structural problems do require structural solutions at multiple levels. So we can't get away from this. There's no way to solve these problems in isolation. And so it really does involve policies, right, that promote racial and economic equity. But it also importantly at the level of our systems is removing structural barriers, to how people can get prevention and can get ongoing care. Considering how to separate the mental health crisis system from school discipline and from law enforcement systems, and addressing immigration policies that cause trauma and harm. So those are some of, in the big picture, the big challenges that we face as a society. But certainly at the level of healthcare, we need culturally grounded interventions that are contextually relevant, and we need training, interventions, and research to be structurally competent. And I would argue that this is often happening more at the level of the clinical care that's being provided, where all of you are adapting to the situations that your clients are in and providing the care that they need, much more than it's happening at the level of research studies where interventions are sort of being developed and tested at these broad levels without attention to these issues. And I say that not to say that there aren't people caring about these issues, but in terms of the way our funding structures have worked, in terms of the work that's been able to get attention and get off the ground, we're really behind on being able to provide culturally competent, evidence-based care. And then certainly, as noted with the interpersonal mechanisms, we have to address both the culture and the interpersonal racism within youth serving systems, within mental health, within systems serving young adults and older adults. And some really practical, things can happen at a clinic level, right? You can use data and quality improvement processes the same way you use them for any other kind of healthcare improvement. You can use them to drive change, to understand who's not being served by programs, and to make changes to that. You need to address the impact of racism on providers of color, because this isn't something that's happening only to the patients, right? And the racism that people are experiencing is also not just in their communities, but in their own healthcare systems and professional systems. We need training, consultation, and accountability, certainly for professionals, but we also need the restorative practices for families for the harms that they have faced in these systems in the past. So I think I'd like to pause here just to let anyone know to take a moment to really think about one of these questions, right? Either what's one priority for your agency or system with regards to equity, or what's one next step that you can take?